Thank you, Norman, and it is an honour to be here and giving you this presentation. I'd like to start by acknowledging the Larrakia people, who are the traditional custodians of this land. I want to pay my respects to the elders on this land, past, present and emerging, and extend that respect to First Nations people with us today. And I want to commit, as many of you commit on a daily basis, that the work that we do does walk alongside Aboriginal people and Aboriginal organisations and will hopefully advantage and make better some of the Aboriginal health outcomes that are part of the ecosystem and system in Australia of which we are so not proud. So in this presentation, I'm going to give you a bit of background. I'm going to acquaint you with the role of the National Rural Health Commissioner and some of the stellar work that has come before me, and then get you a little bit of an idea of the priorities that I can see and really encourage us to have a future focus. For those of you who attended the breakfast, I think you can see that we are in interesting times, and there is a large volume of work and a reform agenda that is swirling around. In the midst of this is the need for enough solidity in the rural sector to ensure that our trainees and that our health workforce of the future can have confidence that there will be roles, responsibilities and fulfilling jobs serving the needs of rural and remote communities to the future. Now this is a picture at Gove or Nhulunbuy, and it does, I think, mention to us that there are some crocodiles in the water, but as rural clinicians and those that live in rural and remote Australia, we're well equipped to be croc-wise. So what I want you to know about this photo is its age, and it does age me, and it was 1980, and it was the time of what I believe was the last major disruption in medical education, and that was started at the University of Newcastle with a fairly visionary dean who decided that he was going to set the scene and train medical students who came from a diversity of backgrounds. And he was going to look to them being related and have a relationship with community. And he was going to think about a problem-based method of learning where they incorporated clinical symptomatology from the beginning. Now, all of those things are now absolutely the norm in our medical system today. So my suggestion to you is that we're probably in a position to think ahead and think that we might need a bit of a disruptor going forward, because if we think about it, this is 40 years ago. Now the other thing about that photo is that I met my partner, and my life partner has been a very important collegiate relationship as we've moved through rural Australia. And the second thing about it is that it does talk to some of the predictive factors of rural return, some, not all. I'm metropolitan origin, Peter is rural origin, so it was rural spousal origin, I guess, but it was the positive rural exposure that we received in 1980 in our first country term in Tamworth, New South Wales. So after what is now what we would call rural generalist training, we decided that with too busy workloads, that our family and our work-life balance wasn't quite right. Our babysitters seemed to know the children better than we did. So off we went to Western Australia to work in remote communities and take up one job. So I think in this you'll see the themes of an opportunity to look at differential ways of funding, so some of it salaried employment, but also that capacity to have the flexibility to move between the hospital and the general practice setting. After 5 years there, again, family issues were the things that made us move. After sending the second child to boarding school, we went, hang on, is this what we actually wanted? We think we might want to move together to a place where the children could have a reasonable period in high school. But hang on, there's a bit of time left before we need to do that. So we went off to northern British Columbia and spent a year in a First Nations community in British Columbia. And here you see the truly multi-purpose service that we see in some of our rural communities and some of our Aboriginal community-controlled environments, where you've got a clinic and a hospital entrance side by side. The other real lesson that I learned here is, as an international medical graduate, I was a square peg in a round hole. My need in that community, their need for me was workforce, all right? It was service. No time did anybody turn around and go, what are the skills that these international medical graduates bring to our community? What are the ways in which we can engage with them as international medical graduates within our system to bring greater benefit to the patients and the community? And we were sorely looking for that and didn't find it. And it is my experience that that is very much how we treat our international medical graduates in Australia, that we don't really look to do a strengths-based approach to what they bring. We see them as a workforce component. I think we need to challenge this as part of accepting that international medical graduates will remain an important part of our health workforce going forward, and we need to think about how we want to integrate them, their skills, into our colleges, into our supervision frameworks. And I guess that's a call out, that right at the moment with this expedited pathway, that it would be really good to see behind the scenes thinking about how these graduates, as they come to Australia, can be made welcome to participate as fully as possible in our rural and remote areas. So we moved back to Tamworth, northern New South Wales in 2004, and other than the golden guitar, it has lots of really positive features similar to many of our regional centres. And the positive features include significant opportunity, and those are opportunities that we took. So Peter retrained in emergency medicine because his skills as a rural generalist were completely unrecognised in an MM3. He couldn't get a job if he wanted to stay active in procedural medicine, despite having a diploma of obstetrics and a JCCE and A in anaesthesia. So he took the choice to spend the next 8 years training to be an emergency physician. I think, again, we need to think really seriously about that. Is that a good use of our health workforce? Are there better ways of doing it? I was very fortunate because I arrived at the same time as the fledgling Rural Clinical School and UDRH program. What a fabulous opportunity for me to be involved in teaching and research. And that RHMT program is a really important and key part of infrastructure, not just for teaching students, but for making careers for those of us who live in rural and remote Australia, and allowing that fulsome participation in teaching, research and other activities that perform part of our ecosystem in rural and remote. So I have a lot to thank that program for, because certainly I wouldn't have had the opportunities I've had. And what I say to people when they talk about a deficit model of rural Australia, I say, listen, I've never worked metro, all right? I've had enormous opportunity by staying rural, and that's the opportunity that I want to keep and I have as a vision going forward. Okay, so what's the gig I've taken up? That's the Act, the Health Insurance Act that enshrines the Rural Health Commissioner, and many people in this audience have been instrumental in 2014-15 in getting the National Rural Health Commissioner into being. And as many of you know, in 2020, it became enshrined as a longitudinal appointment, whereas the appointment Paul Worley took up sunsetted in 2020. So it's a big gig and it's a wide gig. I am not alone. I am supported, and not only by the work that Paul and Ruth have done, but also by two Deputy Commissioners, Faye McMillan, who is supportive in allied health and in First Nations affairs, and Shelley Nolan, who is the Deputy Commissioner who has a 0.2 FTE in nursing. So what's the gig? The Statement of Expectations says that I'll contribute to strengthening Medicare, I'll contribute to primary care, rural workforce and training reforms, I'll support First Nations people's health and wellbeing, and do that by supporting the organisations that we have that work and lead in that area, and obviously the carve-out that you would expect, which is supporting urgent and emerging priorities. So what's the ongoing work that's in the office? Well, the key and the really big one, and the one which we are so hopeful that we are going to land in the next 6 months, is the National Rural Generalist recognition piece, but it's part of a wider piece, and that's supporting the Strategic Council and implementing the recommendations. I'll say a little bit more about that in another slide. But the other things that you may not know about are that Ruth has led a really important maternity service framework discussion, and that needs to be supported through to consensus. And there are some very important advisory networks which work with the Commissioner, and they are going to be extraordinarily important going forward in workshopping some of the government's responses to the reviews and really being able to reflect on unintended consequences and I guess that streamlining of how some of the recommendations could land in rural and remote. So what matters to me? I think equity matters to me, generalism matters to me, and place matters to me. And I've used that as the way of thinking long term, that despite some mixed messaging, which you might see on the other side, that's what I will be trying to lean into. So just talking a little bit more about the generalist pathway, we are hell-bent on supporting the recognition piece. It is at the AMC at the moment, but we are actively making plans for when it returns and when it has a positive outcome. And we have no reason to suspect that it's not going to have a positive outcome. It's really important that the coordination units are supported within the jurisdictions and that the new initiatives around AST and SEM and everything work as seamlessly as possible in offering trainees a pathway that's feasible and manageable. The supporting John Flynn and the increased rollout of John Flynn is welcome, and again, really important that we continue to glue that into the pathway. And can I point to some really important work that's going on? RDA is leading this work on looking at the MBS specialist items in the areas of the accredited skills for rural generalism, so that that piece can be in train as soon as recognition is achieved. And finally and importantly, as we know, in the individual states, there are very different industrial arrangements and awards that recognise or don't recognise rural generalist practice. So that's another piece of work that we need to keep on, so that what we're demonstrating to trainees is that if you choose rural generalism, which many of our medical students are now nominating, that they're really keen on, that there is a pathway and there is an end point where they can see a job and a community where they can go to. Just running fairly quickly across, there's a very important role in supporting and mapping allied health and nursing pathways in generalism, and I really want to call out remote. For me, supporting pathways and recognition of remote area nurses is really key. So I will be working with our nursing colleagues to understand those pathways into remote and those pathways to support and recognise the work that nurses do and RANs do in the remote context. And I'm pulling out remote separate to rural in this particular case because I think a recognition of remote, and if we get remote right, then we will send signals through the system that remote is valued. And I think that value piece, and that's what I'm talking about with rural recognition, is that value piece is so important, and we must continue to talk and validate rural generalist skills. Very quickly, because I know I'm probably going to run out of time, I'm really interested in some sensible, disruptive thinking in the education space. I think the time is right for place-based education and training. I think it should be health service or industry situated. I think we need to think about earn and learn models, and I think in that way we will make it much easier to get a diversity of selection that better represents population need. Skills escalators are certainly the way of the future as we think about all the skills that we will want our trainees and we will want to know as rural doctors going forward. When I trained, I didn't know how to use an ultrasound. You know, it wasn't part of the course. I need the adult learning capacity to then take on those skills. That's what the future looks like. And as I mentioned, supporting First Nations workforce, working within First Nations organisations and supported is really, I think, the way to go. So skills escalators, let's think about debt levels. I think that's the other unspoken piece. We expect people to graduate and move and make decisions based on altruism and opportunity when we know that there are remunerative forces that move people metro. And that's at the same time as particularly our postgraduate students are getting more and more debt. And that's why industry-sponsored or health service sponsors, such as the NT program, I really think is the way forward. I'm really keen to work with specialist colleges on selection and training for population need so that we can ensure that there are generalist clinicians who are able and happy to work in our MM3s and outreach often to our MM4 to 7s. I think we need more longitudinal rotations and the rural immersion theories. We have good evidence coming from rural preferential recruitment about what the likelihood of return is, and we need to lean into some of that evidence. Supportive cross-supervision is obviously really key where we've got low critical mass in some of our regional centres. I don't know about you, but I think multidisciplinary care must be the word that is most used in reviews, documents and in parlance, and yet it's probably something that I'm least comfortable that I know exactly what it is. We've done a guiding paper, and again thanks to Ruth and the office, which is a consensus statement which talks about the breadth and the pillars involved in multidisciplinary care. But I think there's a next piece of work that actually understands the exemplars of what we smell, feel and think multidisciplinary care is. But if we're going to move to a stage where we're measuring it, we really need to test some of the concepts and understand whether we're talking about a caseload model, whether we're talking about a front door model, or whether we're talking about a virtual model that collaborates, and the multidisciplinary nature of it is at the level of the record. To that end, the interoperability of medical records is the other piece in this big puzzle that we're going to need to keep our eyes on. How can multidisciplinary team care work across distance if it is not for the interoperability of our medical records and our capacity to transition and clinical information? So it is good to know that that is the focus of the Digital Health Agency, and you should be seeing over the next little while some of this legislation focused on information sharing and a roadmap for healthcare identifiers. So that is comforting to know. So what's on the horizon? I'm really concerned that we're not thinking particularly ahead about the renewal of our rural infrastructure, and that's a picture of Broken Hill's transmission line that went down the other week. And you can see that it was pretty rusted before it went down. And I think that says something about the challenges in maintaining infrastructure in a country as big as Australia. So I think there's a question on my mind about how and how we, if you like, systematise that renewal of infrastructure, which is absolutely crucial. I'm really concerned about connectivity. It is very clear that with the use of AI and the burgeoning use of virtual technology, that we're going to need greater bandwidth. Now, we do have fibre in, I don't know, 70% of Australia, but microwave or you know, wireless technology and SkyMaster technology look ill-equipped for a quadrupling in speed and capacity over the next 5 to 10 years. I think we need to think about that differently because there is a commercial option. I can honestly say that after struggling with my microwave wireless, I turned on to Starlink and I can get 300 megabits a second and it's marvellous. So what we're going to have to think about is being perhaps technology agnostic, but looking for something about affordability of the technology that we need. We're going to need to use the same thinking about how we manage transport links, which remain crucial for the movement of people and health services in and out of communities. And we're going to need to keep our eyes on the proliferating alternate health service, which is burgeoning in front of us. So Telstra Health, Medibank Private announced a virtual hospital, which they're going to run virtually into rural and remote. How does this fit in with the sort of health system that we're currently operating in? And finally, what about AI? Now, what I'd say to you is, I'm no expert in AI, but I think that the there's enormous possibility in supporting a myriad of particularly clinical decision support and high data areas. I think those of us who work in rural and remote can probably be pretty safe to think that the relationship part of it and the laying on of hands is going to be slower in going to AI. And yet here's the opportunity. So why aren't we using avatars to do our anatomy training in our diversified end-to-end training in our rural and remote sites? Doesn't using some of that technology take away from this have and have not that you need a cadaver to operate on? I think the opportunities are significant. We do need to decide which data-driven reasoning versus human clinical reasoning things we want to give up and how person-centred that is. There's a huge issue in terms of data sovereignty. It's no good saying we need to develop guardrails. The technology is already here, it's already being used. How are we going to get some of that retrospective regulatory framework around some of it? And yet, let's not lose the opportunity. So finally, I think I'm talking about workforce skills and scope, and you'll hear me an absolute champion for generalism. You'll hear me an absolute champion for place, and I hope that you'll see me working towards an equitable system. I do want to map and build the evidence base for multidisciplinary care, and I do think that that's a gap that all of us need to cooperate on, and you will be being tapped on the shoulder to become part of the advisory groups for the office to try and give that advice. And I will say that I'm going to head forward because we need to focus our learning environments and we need to embrace that digitalisation. I think for me, and this is the dilemma that I've got, is I've got to know, and I think what you need from me is I'm not the only door into government. What you need from me is I need to know what the bits are that what's my sphere of influence and how can I affect positive change. But what I do know is, as it was said this morning, that we're a sector that does like collaborating and we do like solutions. And I think, if anything enough, we are the sector that's brave enough to adapt to a different time ahead. So I hope to travel that journey with you.
You can't disappear that quickly, Jenny, you know. Describe what disruption might look like in education and training.
Well, we've got to look at important regulatory standards, but we've got to work out how to interpret them differently. I guess that's what I was saying about the anatomy. I think there is a different skill set going forward. I mentioned it in terms of high quality clinical reasoning. I think we need to know enough to be able to go off an algorithm. But I think there is a whole lot of a big knowledge piece that we probably need in our back pockets rather than learning by rote. So I think the days of, you know, spending 30 plus hours in an anatomy lab as a regulatory requirement are open for disruption.
So give me a sense of how you move forward on that thinking as the Rural Health Commissioner. So
a document that came out just recently called the Universities Accord, I think provides some way into this. So obviously the education sector, and at the moment you would think that I'm talking about the education sector in terms of universities. I'm actually thinking a bit wider, and I'm thinking that industry is our major partner. And when I say industry, I really mean health services. So I mean general practice and I mean health services. And I think if they're partners in it, then the university bit, which might be earn and learn, so you might have 20 hours working in a general practice, and you might be assessed on communication skills and a number of your, you know, absolutely core components of your course in your work hours, and then you've got hours that you do your online course and you learn the things that you're not going to learn in that environment. Look, I'm thinking forward, I'm thinking big, but as I said, 40 years since the last disruption, I think we've just got to look and see what are the skills that we're going to need in a rural community, for instance, in 10 years' time.
So you've got a national brief, and one assumes that eventually national recognition will come for rural generalists, hopefully sooner rather than later. AMC, are you listening? What's the work that needs to be done at jurisdictional level now? Because some jurisdictions, Queensland's well ahead, and so what's the work that needs to be done at jurisdictional level to capture the benefits of national recognition?
Significant work, and I guess that's, I see that as really pivotal. Gluing up the pathway, trying to find a nationally consistent framework that states can be different in, I think is the piece of work. Now, clearly, as you've said, recognition of RG skills and a range of RG skills is different in each state. But interestingly, the need for RGs is also different. And I think that's, in the first 6 weeks, that's what I've really come to realise is it's not only, if you like, the maturation of the pathway, but it's also the need does look different and will be salaried in some spots and can be potentially fee-for-service or GP VMO in some spots. There are going to be some spots where the MBS item numbers are going to be crucial because it's actually a community focus for that generalist skill.
And I mean, how much of it is education at the jurisdictional level? I mean, Queensland, there's no accident that Queensland's where it started because it's a much more decentralised state, much more...
You're right. Geography is a great assistance.
So how much ignorance is there, if you like, to start on the negative at jurisdictional level of what the potential is here?
I wouldn't call it ignorance, but I'd call it failure to grasp the future benefit. And I mean that very sincerely because I think you're right. I think part of it is about education. They're being measured on a budget bottom line. Rural generalists and care closer to home, particularly higher acuity, wider scope practice, is actually so much more efficient and less costly for the health system. But I think getting that message through that a rural generalist will save you money is probably the most important message.
And with multidisciplinary teams, I mean, I think that would rang a bell with a lot of people here. I mean, what the bloody hell are you talking about?
I know what it smells like. I know what it feels like. I just can't describe it.
What's the risk here, given that primary care is, in a sense, governed by a centralised entity, namely the Commonwealth? What's the risk is that it will be prescriptive and not adaptive? You know what I mean? Somebody will say, well, this is a multidisciplinary team. This is what we'll reward. And everybody else can get stuffed, even though it might not suit the local community and the workforce. I
think it is a risk. And it's a risk because I think the Commonwealth genuinely needs to have a cost efficiency approach. So it's got to know that if they're going to put a blended payment in there, that there's an outcome, which is an improved health outcome or a measure. And I think they're struggling to work out what the measure is, and I think we are too. I think rural and remote can lead here because I think, as I said, we have exemplars, we've had exemplars that have been running for 50 years. So the science is there, the experience is there. The question is, as I said, how do we build in flexibility to allow those systems to flourish and yet provide the right drivers for others to collaborate to produce it. I think that's why. I think that's the issue. I don't have a specific answer. I think you've nailed the issue from my point of view.
Well, there's 850 people here who wish you well.
That's right.
Thank you, Jenny.